All right, we are at the hour, so let's get started. Hi, everyone. Thank you for joining us and welcome to the American Indian and Alaska Native Tribal Opioid Response webinar series. My name is Jeff LaDolcher, and if you haven't met me before, I'll be your point of contact for the Tribal Opioid Response Technical Assistance. This webinar series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which includes 10 regional centers and a network coordinating office. To learn more, you can visit our website, which is linked in the contact and support box that you see at the bottom of your screen. Our center is a NADAC certified educational provider, and we'd be happy to provide you with continuing education units for a $15 fee. The CEU request form is available for download in the Files pod on the webinar screen. And immediately following today's webinar, you will be redirected to our GPRA evaluation form. SAMHSA asks us to evaluate our events in order to provide improved performance assessment and accountability. It will ask about your satisfaction with the event, and it will take less than 5 minutes to complete. Completing these surveys helps us keep bringing you these meetings like this one, and we would all really appreciate you taking the time to give us some feedback. You will be muted for the duration of the webinar, but you can use the chat pod to share your questions and comments, and we will address questions at appropriate points during the presentation. If you have a question specifically during the presentation, you can also let us know by clicking the icon at the top of the window that looks like a little figure raising their hand. Today's speaker is Dr. Paul Gilbert. He is an assistant professor in the Department of Community and Behavioral Health at the College of Public Health at the University of Iowa. His research addresses the ways that gender, race, ethnicity, and sexual orientation shape drinking patterns, risk of alcohol use disorders, and use of treatment services. He also focuses on improving the health of Latino communities in non-traditional settlement states through participatory, action-oriented research. And with that, I am going to hand it off to Dr. Gilbert. Sorry about that, Scott.
Okay, hello. Now it looks like I'm unmuted. Great. Thank you for that introduction, Jeff. And I'm very glad to be here chatting with everyone today. Thank you for joining the webinar. What I've got in mind today is to talk about 4 things that I think are really key to the public health approach to essentially any sort of problem, but we're focusing today more on the opioid crisis and substance use generally. That's my area in particular. So my intention here is really to take some of the key things that those of us who have public health training, who may have gotten an MPH, will learn through that training, but to relay it to folks who don't necessarily have that training, some of these useful approaches to planning your prevention response or whatever you're going to do. So go through each of those 4 areas that you see on the screen here, talking about levels of prevention, planning models, community readiness, and then evidence-based interventions. After each short section, I'm going to pause so I can answer any questions or if you have any comments to share. And again, as Jeff said, I think participants are all muted right now, so you'll have to type in your questions in the chat box. And then at the end, I've got 2 additional thoughts that I will share with folks. So let me move on first here to our first idea is levels of prevention. And this is maybe a bit of jargon. It may be better to think of it as types of prevention. But I use the word levels of prevention because that's what folks with public health training will talk about. And you should know that language, at least know what it stands for to recognize it. Let me show you on a table here and I'll flesh this out with some examples about what I mean here. When we talk about levels of prevention, the words we use typically are primary and secondary and tertiary prevention, like you'll see in the left-hand column here. And you could think of it essentially in that order of first, second, or third steps to preventing whatever problem is. They differ a little bit in terms of what actually is going on or what that type of prevention is. And that's where on the rows here, I've explained just very briefly the aim of it, and then I'll give you an example of each in a moment. But for primary prevention, this is really the hallmark of all public health work. We talk sometimes about how our successes are non-events. The outbreak of disease doesn't happen. The premature death doesn't happen. The crisis is averted. That's the ideal, and it's really hard to measure. As you can imagine, if something doesn't happen, how do you know that you're responsible for it or you contributed to that in some way? But this is the notion that we are getting at when we talk about primary prevention, avoiding the problem in the first place, and oftentimes that's through minimizing the risk factors that are going to lead to the problem. So in terms of substance use, and the opioid crisis especially here, some examples of primary prevention might be a prescription drug monitoring program to keep track of who's being prescribed, what types of medications, in what quantities, looking out for duplicates, just sort of keeping track on the availability of opiates out in the world. A component to that, or I guess something to go along with that, would also be something like a safe medication disposal program, so that we don't have pills lying around that somebody might misuse, that once you're done with your prescription, you can safely dispose of that somewhere. Those would be examples of primary prevention. The next layer down, if we go down to secondary, that's a little bit further along in the process. And in this case, we typically think of the problem has happened, there is the case of disease that's occurred, but we want to get in and address it as soon as we can. And sometimes it means screening for things or looking out for problems before they become readily apparent, before symptoms present, before somebody notices that there's a problem there. The earlier we can get in, oftentimes the easier it is to intervene to change a situation. So the way that we talk about it, the way that we define it, is detecting a problem early and then doing some sort of intervention early in the course or the development of that problem. In this case, for substance use or opioids in particular, an example of secondary prevention would be something like screening and brief intervention and referral to treatment. And you may have heard about this. You may actually be doing that depending on who's in the audience, who's tuning in. But this is where we include screening for substance use problems, say illicit drug use, hazardous drinking patterns, into regular health care. So we may be doing that as a quick set of questions as we take somebody's vitals, as we check somebody in, or maybe as part of a routine follow-up appointment or aftercare, just checking in. And then if we do detect a problem, we can develop or deliver a brief intervention, say some brief counseling. Oh, it sounds like you're drinking more than most of the people in our community, in our population. I'd like to give you some resources. I'd suggest you talk to somebody. Would you consider cutting back or even stopping drinking, whatever it might be? But that's an example of what we mean by secondary prevention. But of course, if we go down here, we've got tertiary prevention, the third step, and this continues sort of the development of the problem. At this point, we know that there's a health problem. We know that there's a case of disease or a crisis has developed. And really what we're trying to do here is minimizing the damage. And oftentimes in communicable diseases, this means minimizing the spread of the disease. So it could be quarantining somebody who's infectious. The example that I have here in terms of prevention and substance use could be not just delivering treatment, but also adding things like case management or wraparound services or integrating that treatment. So we know that the substance use disorder has happened. We're addressing that, but we're also going a little bit above and beyond to try and take care of everything else that either may have contributed to it or the other negative effects that may come from an individual with a substance use disorder. This could be family or other community effects. There may be other supports needed or other services to integrate with that. So this brings me to a question, and for each one of these topics that I want to talk about, I'll leave you with a question to consider. And that is, as you're thinking about mounting some sort of response to the opioid crisis in particular, or to substance use, or in fact, any sort of health problem facing your community, one of the first things I recommend doing is thinking through what type of prevention activity you need to do. And I wouldn't necessarily say that one is more important than the other, even though I said that primary prevention is a bit of a hallmark of public health work. They're all necessary. You may actually attempt to do multiple types of prevention, or you may decide you really want to emphasize one particular type of prevention. But this is something to think through early in planning your response, is exactly where on these levels or types of prevention you want to have some sort of action. I'm going to pause for a moment to see if anyone has any comments or questions here. And again, as participants are muted, you'll have to type into the chat box. So I'll pause just a moment to see if anything pops up here. Okay. I don't see any questions, so I'm going to move on. The next topic that I wanted to talk about is intervention planning models, and this actually brings us to a difficult step. It's about planning to take action, getting prepared to do it. I'm going to show you and walk through very briefly 3 different planning models that are very widely used. I'm actually going to recommend one of them, but I want to make sure that folks are aware of the 3 approaches and have a resource to go to if they'd like to use any one of those. This is only going to be a quick overview of each one. In fact, we could probably spend a whole webinar on just one of these planning models. And I know in a lot of our courses that we take as public health students, we may even spend a whole semester working through one planning model in particular. So I'll just acknowledge this is going to be a quick overview and that there's more to it that you can dig into. So the first model that I want to draw your attention to is called MAP. That's the acronym. It stands for Mobilizing for Action Through Planning and Partnerships. This is actually the one that I recommend most widely when I work with community folks, and that's because it comes out of NACHO, the National Association of City and County Health Officials. And in essence, this guide was written by the people who do health planning in communities for their peers doing health programs in communities. So it's a very accessible guide. It's written to be technically and scientifically sound, but also put in plain language. So I think it's very, very useful, very good. It also puts a lot of emphasis on aligning different actors, different agencies or different organizations, sort of bringing the community together to tackle a problem, which I really appreciate. I'm going to show you quickly for this and for each of the models that I'll present just an illustration of their approach. So here you see a diagram that comes with the MAP planning model, and there's a number of different steps here. We've got arrows mostly going from the top to the bottom in the planning with action at the bottom, but we've got these arrows around it showing that essentially there are ongoing and overlapping and continuous processes about the planning. But one of the first things to note here is they start the whole process by looking at who's going to be partnering to do your health program, who are you going to try and bring together. Again, I mentioned that they put a great emphasis on aligning agencies and organizations, and that's really apparent from the beginning here. Developing, in essence, coalitions to tackle a problem. That's a very important first step in the MAP approach. They also, shortly after that, emphasize doing very thorough needs and strengths assessments to get a sense of what either the resources or the gaps in the community are, what you've got at your disposal, what you're going to need to address before you even get to the action steps. And then as we work down here, you'll notice there's a sort of a circular pattern here of arrows going around the action. When you finally reach that step of taking action, of implementing your policy or your intervention or your program, you're actually going to be continuing to do the planning process and doing some evaluations that are going to feed into the planning and the action, and then more evaluations. That it's this ongoing iterative process here. I think one of the other things that makes the MAP process really appealing, besides, as I said, being written by the people who do health program planning for people who are doing health programs, is that it's available free of charge. You can download it from the website on the slide here. And I believe Jeff or somebody may have already sent out the slides here. They'll be available, so you'll have these resources. But I do think that this is a really, really good resource. It's widely available, easy to follow as a sort of guidebook of the steps to go through, written in plain language, no cost to get the guidebook here. So I definitely recommend this if you're considering planning some sort of health promotion, whatever it might be, action or program. But now I'm going to turn to the second planning model. This is really widely used, but it tends to be more in academic circles. So the folks who are developing interventions in a primary step that hopefully will be then disseminated to community partners. It was developed by a couple of academics in the 1970s, Green and Kreuter, as a very comprehensive and detailed planning model. This is one that's taught in public health classes very often. A couple of the hallmarks to note on this is that it focuses on both a thorough assessment of the conditions before you get to any action, and then also focusing on a thorough assessment of outcomes of what you're ending up, whether you're successful or not in what you sought to achieve. This particular model is promoted by the Centers for Disease Control and Prevention, so that's nice to know. But let me show you a bit of the diagram here and explain a little bit of it. I frankly find it a little bit less intuitive than the MAP process, but there are guides that walk you through all the detailed steps and that explain it very carefully. What we see on the screen here really is the diagram of the process, and if we start in the upper right-hand corner of the box with the pre-seed steps, you'll see that we go through 4 steps of very detailed assessments of the environment, the social conditions, the epidemiological conditions. All of these things are going to be building and gathering information to characterize the problem in both strengths and weaknesses or deficits or things that we need. As we work our way around the side and then down to the bottom, from the lower left side, we're working to the right at actually implementing and evaluating whatever the activity is that you are planning to do. And here we've got several steps, kind of analogs to the preliminary assessments at the top. At the bottom, we've got 3 explicit steps of different types of evaluations. So this is the sense of, as I said, is a very thorough and comprehensive assessment, both leading up to your intervention activities and then following on your intervention activities. Things like the process, how did it how was it implemented? Was it implemented as planned? The impact or outcome assessments, and oftentimes these are described as short or long-term effects of your activity. In the middle here, in the green boxes, you see we've got essentially a conceptual model of the factors that are going to be contributing to the end result as we work through the different steps of assessing and evaluating it. And in this case, if we start on the right-hand side, the ultimate outcome of our intervention is going to be improved quality of life. The way that we get to that is through improving health status and, linking back another step before that, changing behavior or changing the environment. But we're going to continue working backwards, back from right to left, to identify what are the factors that are influencing our health outcome. Could be genetic, certainly there's a behavioral component, and definitely an environmental component. And then you see the next step antecedent to that, coming before that, are predisposing or reinforcing or enabling factors that will have some sort of relationship with one or multiple of these different factors. And then at the far left side, we have whatever our intervention is. And this is a general framework that could be applied to whatever topic, whatever health problem, whatever activity you're doing in response. We have our intervention at the very left-hand side that's going to set something in motion through all these different sets of factors, the predisposing, enabling, and reinforcing conditions, the genetics, the behavioral component, the environment, the final health, and then ultimately quality of life outcome. But already you can probably see that this is more detailed. It's a little bit more to grasp than the MAP process. Although honestly, with MAP there are several steps arranged kind of in a linear focus or a progression from top to bottom there, assessment to action, but with that iterative step. This is a little bit more detailed. As I said, though, there are resources available, and we actually have a textbook here by the originators of the program. This is the latest version here from 2005 that explains each of the steps and walks through it. But, as I said, this is often the basis of a whole semester-long course in intervention planning. It is available if you're interested. As I said, it is a planning model recommended by the CDC, but there is some expense here, at least if you're going to buy the textbook that explains it. And frankly, I think it's a little bit more written for the academic or the technical or the specialist audience. So I want you to be aware of it, that it's out there. But yeah, I'll leave it at that. The third and final model that I want you to know about is called intervention mapping. It has some overlap with precede proceed, the one that I just talked about, because it was also developed by academics. It's also used pretty widely in academic settings, but this is a more recent development, and it has borrowed some of the aspects of precede and proceed, especially some of the thorough assessments that were part of the initial steps, the initial 4 steps of the precede-proceed model. It is comprehensive, but has a fewer number of steps, 6 instead of the 8 in precede-proceed. It does emphasize using theory, drawing on evidence, and participation by stakeholders. The one other characteristic of it is that the originators are pretty clear that it's not always clearly a linear progression, that you'll go back and forth among the steps. And in fact, the whole model is designed to be iterative, to go back and forth through it. So let me show you a diagram here. Some of the text may be a little small and hard to see on your screen, so hopefully this will be more legible in the slides that you have. It follows a very similar process as the others, as the MAP planning model and as precede proceed, in that you're working through these steps from the top down primarily, beginning with a description of the problem using a logic model, a specific way to draw a diagram of the problem, the resources, and what you may be doing. Also, it includes assessment steps, as I mentioned. And then you're working your way ultimately down to doing something, taking action, and then ending with step 6, an evaluation of that action. The whole thing is designed to bring you back again to the top to revisit your logic model, the one that you started with. You can revise it and then continue through the planning. This is actually very similar to the map, the initial model I showed you, where when you get to that action step, it's very much iterative. You have these circular arrows going around it of action and evaluation and planning that leads to more action and evaluation and planning. But there is some wiggle room here, not necessarily shown with the arrows, but to go back and forth along the steps here. Like the previous one, there is a textbook to teach intervention mapping, and like the previous model, it oftentimes is the basis of a semester's long course on program planning. There's some of the same drawbacks here as precede proceed, is that it tends to be a bit technical, a bit full of jargon, definitely written for specialists. It is widely available. If you wanted to purchase the book, it does walk you through all of those detailed steps, just like the precede proceed textbook does. But there is a cost involved to getting it. And this leads me to the next question I'll leave you with. After figuring out the type of prevention activity, the level of prevention you want to do, before you get to actually taking action, you'll need some sort of framework to guide it. So the question is, which planning model would you use? And I've given you 3 that are commonly used. And as I said at the start, I definitely recommend the MAP model. But you should be aware of all 3 that they're there. There's a whole lot more detail involved in each one than I'm able to go into right now. But I'm going to stop here as well to see if anybody has any questions or comments. If you'd like to type anything in the chat box, I'll pause for just a moment.
Actually, Dr. Gilbert, I have a question, if you don't mind.
Sure.
From what I understand about a lot of the TOR grantees, is they're implementing mostly secondary or tertiary prevention. So they're either screening, intervention, withdrawal treatment, or just harm reduction and actual substance. What would you recommend for grantees that are either starting prevention programs or even considering whether or not to implement? What would be the best starting place if you're starting from scratch?
Well, probably one of the common themes of all these prevention planning models is doing some sort of assessment of what's the situation, what are the circumstances. That's a really good place to start to get a good grasp of the nature of the problem. And this could be what we oftentimes talk about, sort of hard data, the epidemiological characteristics, how many people are affected, what's the extent, what's the burden, what's the incidence or prevalence of something. But you may also be doing more of the sort of social assessments of what's the perception of the problem, how much do people think it's important. Actually, this is a good question that leads into the next thing that I'll talk about. And by doing that, getting a handle or a sense of what the extent of the problem is, the characteristics of the problem, may help you figure out the type of prevention or give you a sense of what might be needed in response. All of the things that I've talked about so far are meant to be general and widely applicable to different communities, different types of problems. You could use any one of these planning models and assess what level of prevention you want to do for any sort of situation. It could be obesity, it could be a measles outbreak, it could be substance use, it could be a mental health problem. They're meant to be widely available. But I do think just getting a sense of the scope and the nature of the problem is a good starting point.
Okay. I actually had one other. In the MAP model, it looked like one of the first steps was, well, after assessment, was developing a partnership or a coalition.
Yes.
Like the Omaha tribe commented that they do community outreach using case managers with child protective services, with clinic referrals and law enforcement referrals. Do you think you can give a few examples of uh, some kinds of organizations you could partner with specifically for opioids?
Yeah, and in fact, the Omaha tribe, it sounds like that would be a great example of having these different either organizations, agencies involved. Oftentimes, well, I should say my work in Iowa is primarily focused around alcohol, um, and some of our typical partners are, aspects of the criminal justice system, whether it's the courts, local law enforcement, but also schools are always important, and that could be primary or secondary schools, but also community colleges, um, uh, any sort of local civic groups. I've been in groups where we've drawn on the Rotary Club or neighborhood associations even. Uh, they all share that sort of common purpose of prevention. Um, One of the things that the MAP planning model I think is good about is, or recommends, is thinking creatively and broadly. Who else in your community might uh, be important to involve, either because they have an important role in the community or they are connected in some way to resources or they control something or yeah, we just extend sort of this notion of working in coalition. Trying to think if I've got, churches. That's the other entity that's very often involved in the community work that I do. We almost always have representatives from local churches involved as well. So we're moving nicely in with these questions into my third area that I wanted to talk about, and this is assessing community readiness. And I was initially going to say that I think this is a particular case of preparation, may warrant special consideration before you get ready to do any sort of action. I have a few bullet points here about the justification for thinking about community readiness. Oftentimes we talk about how it's a necessary component of any long-lasting and sustained change. You have to have the community, if not directly involved, at least supportive, at least on board, that our response to whatever the problem is necessary. There's also a couple of other advantages to making sure that the community is engaged and supportive, is that you can have more effectiveness with whatever your intervention activities are. You might get feedback from the community, which leads to better tailoring to the local conditions or local needs. One of the cautions I'll give, though, is that it's really necessary to think through how you're going to define community and to be clear about that. In general, there are three ways that we in public health will define community, and the simplest and most straightforward is geographically. It could be bounded by the town, or there's some other boundary, a school district or something like that. But we also may define community by shared characteristics. Oftentimes I'll talk about, say, we think about minority communities, the African American community of Iowa. They may not know each other. They may not even think of each other as a community, but there's something that sets them apart as a cohesive group. And then there's also defining community by function, the things that people do or the behaviors, which could be bus riders or clinic patients, clinic attendees, or injection drug users. Again, they may not necessarily identify that as a community or see themselves as part of a community, but there's some aspect that sets them apart as some sort of commonality, I guess, that unites them. So those are the three common ways that we define community. Now, my original intention was to show you this screen and point you to this website. This was part of the SAMHSA website, where there are a number of assessment tools. I happen to like things that you can use as a recipe book or a guidebook, things that will lay out the steps to take, the questions to ask, the people to look out. And I have to tell you that shortly before getting on the webinar, I looked at this website, or I went to look at it, and I couldn't find it anymore. It seems that SAMHSA has reorganized their website since the last time I looked at it, and this page is no longer available. I'm going to follow up so we can send out a list of other places to look for guides. There are plenty of resources out there that, as I said, serve as sort of recipe books of steps to follow and questions to ask when gauging community readiness. You may be able to make out on the screen here the screenshot from the old website. It will list the name of the tool, some of the characteristics, the number of questions, the topics or the people that it goes into. And these are not specifically about substance use or opioids, even though it was hosted originally by SAMHSA. But this is more general guidelines for whatever the problem might be, assessing how ready your community is to take action to address it, essentially. So this actually brings me to the third question that I wanted to leave people with, is to think through how ready your community is to engage in prevention work. And again, I apologize that the SAMHSA website is no longer active or current, but I can send some follow-up information about where to find that. I'm going to pause for a second again to see if anybody has questions or comments that they want to make.
This would be a great time to hear a little more from our participants. If we have any courageous members in the audience, we'd love to hear any steps you've taken towards kind of opioid prevention.
All right. Well, I'm sure we'll have time at the end for questions and discussion if anything comes up. So let me move on to the fourth topic. This is actually a big one, and you may notice we're sort of working in a progression towards action, similar to the way a lot of the planning models talk about laying the groundwork or getting prepared. So we started by thinking about the type of prevention, wanted to expose you to different planning models to go through that preparation process, wanted to call out community readiness and assessing your community's willingness to address an issue as a particular thing that you might think about. But now we get to the point of actually taking action, and I wanted to say a few words about evidence-based interventions. Again, this is a big topic, but it's something that is emphasized more and more often in public health. People are calling for the use of evidence-based interventions. This oftentimes comes from funders who are asking folks who are going to do anything that they have to select an evidence-based intervention. So I wanted to go over a little bit of that here today. In a nutshell, very briefly, when we talk about evidence-based interventions, we mean something, some program or policy or intervention, some action that was developed in a rigorous and scientific way, and oftentimes that means that it was based in some sort of theory about behavior or theory about behavior change, and has been evaluated rigorously, scientifically, has demonstrated some good evidence that it achieves what it sets out to achieve. And I tell people oftentimes you can think about it as having received a stamp of approval, that this should be a good, trustworthy activity that somebody else has come up with that we might consider implementing in our own local community. there are a few reasons why EBIs are getting a lot more attention and are sometimes even being required here. Um, because of this development process, as I said, where it's scientific and rigorous and evaluated thoroughly, we have better likelihood of getting the outcome that we want, of achieving the ultimate goal that we set out to do using evidence-based interventions. Some of the other advantages here are that we avoid having to duplicate efforts. And what I mean by this is that we don't necessarily have to start out by developing a new um, intervention to address the opioid crisis if somebody else has developed something that we could take and adapt and use in our local session or community, I mean. That we don't have to start from square one, or we don't have to reinvent the wheel, as they say. Also, this can be a stronger justification for resources. You know, time and money and personnel are always in short supply, are always tight, and it makes a better case oftentimes to say we're using this rigorous evidence-based intervention. We can make a better claim to using our resources for something like that that has been tested and shown to be effective. The fourth point here, as I said before, sometimes this is even being mandated by funders. They'll ask us to use an evidence-based intervention. The last point, and from my perspective, what I really appreciate is that this is a way to bridge the academic and the practice worlds. Oftentimes it's those of us at universities and academic settings that are developing these programs that ultimately turn into the EBIs that are then disseminated once they're shown to be effective, that we hope that are going to be taken up and used more widely. But oftentimes without this, we don't always have a lot of connection back and forth between the folks who are actually doing the work, the practice, the real world, and the academic ivory tower world. So I appreciate the aspect of EBIs that they lead us to more collaboration back and forth. So, where would you find EBIs? I pulled out 4 recommended sources thinking about the opioid crisis in particular and American Indian communities in particular, 4 places to look. There are a lot of directories online. There are a lot of places to look. Probably the most common, which is not necessarily on the screen here, is the Community Guide. This is a website run by the CDC that is probably the most extensive directory of evidence-based interventions or other sorts of summaries of what we know about possible interventions. I did not include that website on this screen because, frankly, there isn't a whole lot of content specifically for American Indian communities, and the ones on the screen get a little bit closer to it. The Community Guide may still be useful, particularly because it's such a expansive directory, but it's also going to be it's going to mean some extra work that you may find an intervention that looks good, that looks promising, but it was developed in a different place and for a different population, so it's going to entail a little bit of work to adapt it or to translate it or to make it appropriate for your own community. Continuing in that vein, I'm going to tell you that there is a framework that I like in particular about adapting evidence-based interventions. You see a little screenshot of a table. Essentially, this is like a worksheet that you can go through. This comes from the Cancer Prevention and Control Research Network. You can find it online, and in fact, if you follow the link or even Google the CPCRN adaptation framework, they have a lot more supporting documents online where they'll walk you through the steps of their tool here. But this, again, is a really handy framework for looking at what you're trying to do in your community. Say you want to develop an opioid prevention intervention, and you find something that an EBI, an evidence-based intervention that looks promising, that looks close. You can assess the overlap with your goals and the goals of the EBI. You could also look at your community characteristics and how closely it matches the population or the setting where the EBI was developed. And then it'll walk you through a process of deciding whether you need to change anything and what level of adaptation or the extent of adaptation is going to be acceptable. And there are some types of adaptations that you are recommended against doing because it will interfere with the core functioning of the intervention. It'll take away from some of the essential features. All of these CPCRN materials, the framework and the background supporting documentation, is available at no cost. Again, makes it very appealing for folks in the community. And it is fairly straightforward. Or I should say, it has a lot of common sense steps, but there are a number of steps and a number of details to work through here. To help out with that, I'll just point out that some colleagues and I at the University of Iowa, we're in the Prevention Research Center, we did a webinar on essentially what I just talked about, finding and then adapting evidence-based interventions using the CPCRN framework that I just showed you. You can find a recording of the webinar at either one of those websites on the screen here. That's available if you wanted to watch it at any time later, follow along. But as I said, we worked through some of the steps of the adaptation tool. We also show a little bit more detail of the community guide and how you might search that CDC website and finding interventions. Oh, I just saw a note that those links aren't working. I will have to double check. If there's a correction and there could be a typo, I will send out a correction. Let me double check that right after this. But this leads me to the fourth question corresponding to this area here that I'll leave you with, is to think about whether there is something out there already developed, an evidence-based intervention, something that's rigorous, that shows signs of effectiveness, that you could use in your local community once you've reached all your or gone through all your planning steps of assessing the problem, figuring out what you're going to do, the level of or type of prevention activity, and so on. Is there something that you could use, and how much might you need to adapt it if you are going to use something? Let me pause again just for a moment to see if anybody has questions here. So the four main topics that I talked about today, I really wanted to give you an overview, as I said at the start, because I think these are some of the core features of public health approaches, things that we learn in public health training that I wanted to make sure to share with people. I'm only giving a very quick overview, but hopefully leaving you with resources, or I'll be following up if the links are broken, places to go or where to find more information if you want to dig into this. But I do want to leave you with a couple of concluding thoughts that I have specifically about substance use issues and the opioid problem. And this may prompt some discussion as well. One of the things that we hear about a lot lately is naloxone, and that seems to be part of a lot of local community responses, is getting naloxone out so it's more widely available. And I am definitely in favor of that. I think this is an essential resource. It is a life-saving resource. But I also want to make a comment that it's not treatment. It will prevent a death. It will reverse an overdose. But it also can prompt a lot of problems. One of the most immediate is that for the person who is experiencing an overdose, oftentimes it triggers withdrawal immediately, which is really painful. It can be very uncomfortable. You may be surprised, and first responders oftentimes are surprised when they do deliver naloxone, that somebody is very angry that their high was cut short and that they were essentially, whatever, it's like flipping a switch and sending them into withdrawal. It's not treatment for the substance use disorder, but is an absolute essential resource to prevent a death. So we just need to be aware of what it's good for and what it can do and what it doesn't, and that it doesn't necessarily end a substance use disorder there. But along the lines with ending a disorder, one of the things that I have to admit I've come to kind of recently, it was only a couple of years ago that I heard about the whole well-briety movement, but I find this so appealing and intuitive, and I think it's worth highlighting that this comes out of American Indian communities, and I try and draw attention to it more widely now. And that's the notion that recovery is more than just sobriety. It means more than just not using the substance that was the problem to begin with. And it takes a much more holistic view of well-being within the family, within the community, that it's not just the individual's behavior that's changed, but it's a whole comprehensive sense of wellness. In a lot of ways, this reminds me of the World Health Organization's definition of health. And they've got this really nice statement that I'm just going to paraphrase. I don't know it off from memory, but the WHO says that health is a complete sense of wellness and well-being. It's not simply the absence of disease. So I see a lot of parallels here with this well-briety movement, that it's not simply the end of substance use, but a more holistic approach to well-being. And I wanted to highlight that. You probably are much more aware of it than I am, but it's more culturally congruent as an approach with American Indian communities. And white bison is probably the most well-known example here. And as I said, I'm trying to draw more attention more widely to this idea. So I'm looking at the clock, and it looks like we've got a few minutes left before the end of our time. So if we do have more comments or questions or discussion, we can move to that. I want to leave you with my contact information here. So if there's any follow-up where you have questions, want advice, anything that might come up, feel free to reach out. Excuse me. You've got both my email and my telephone number there, and I'd be happy to talk with anybody about any of this, because I do realize that I went over a lot of big topic areas fairly briefly and fairly quickly. So with that, I think I'll pause again to see if there are any other comments or questions from folks. Let me ask a question to Jeff. Have you sent out the slides already?
I have not, but they are available for download in the files pod. They're titled.
Okay, because I'm going to double check all of the websites, the links that I included in the slides, and if I have any corrections, I'll let you know, so we can make sure to get the most recent out there.
And I just want to say, today we've talked about prevention in pretty broad strokes. We really covered the building blocks, but if you're looking for some specific technical assistance, please don't hesitate to reach out to me. My email is at the bottom of the contact and support box. There may be something that we can offer, either in person or not in person. This is a type of technical assistance that we could provide.
Mm-hmm. And I believe next month, I don't know the date, but next month I think my colleague, Dr. Shelley Campo, is going to be doing a similar webinar on specifically community, something about communication campaigns or persuasion campaigns. Do you know, Jeff?
I don't think specifics, but yes, that will be next month.
The gist, however, is that she's going to go more in detail into a specific approach, whereas I talked more generally about the things that we think about when we plan prevention campaigns. All right. Well, if there are no other comments or questions, I apologize for some of the links not working, but I'll try and get updated ones and send that out. Um, as I said, feel free to reach out to me either by email or phone if you've got any follow-up questions or any seeking any advice or assistance with anything. I'd be happy to chat with anybody.
All right. Well, I think I'm going to end it here if there are no more questions. I want to thank everyone for joining, and I want to thank our presenter, Dr. Gilbert. Um, just a reminder, when the meeting ends, you'll be redirected to a survey evaluation. It should only take about 5 minutes, and we'd really appreciate it if you could fill those out. Dr. Gilbert, do you have anything, any any final comments?
Nope. I hope this was helpful, at least to give you some initial things to think about and resources, steps to go forward if you want to follow any of these, like the planning model, assessing community readiness, or looking for evidence-based interventions.
Right. Well, thanks to everyone. I'll be ending the meeting.
All right. Thank you.